Well, good afternoon, everybody. Congratulations on getting through the snow and arriving on a cold day to our monthly grand rounds. Today we have a fascinating topic that I've watched with interest over the last 30 plus years, from a mystery sort of non-A, non-B hepatitis to something that we realize the full extent of the problem and then have moved on to actually effective treatment. So it's actually been like not that long, 30 years, to actually understand there's a mystery, there's a real problem, right through to there's potential solutions. Unfortunately, they probably do cost a bit of money. Anyway, Steve Johnson from the Department of Medicine is very welcome to come to talk to us today about hepatitis C. Thank you very much.
Thank you very much. Thank you for attending and braving the snow and ice here. I'd like to talk to you about the challenge of hepatitis C. And Mary's right, it's gone from a mystery disease to one that is completely curable. In a really short period of time, just not working? Not working. The green light. Yeah, you can tell that one's on. That a little better? So I think the interesting thing about this virus is it's gone from a mystery disease to one that is curable. And so really, we won the game. I think we should have won the game, but I'm not sure we have. So what we're going to talk about today in the short time is I'm going to discuss some of the natural history of hepatitis C. We're going to talk about the epidemiology of hepatitis C both worldwide and in New Zealand. We're going to talk briefly about treatment options. It gets really boring really fast if I start talking about a lot of drugs. Half of them I probably can't even pronounce right. We're going to talk about barriers to treatment. Why have we not won the game? And that's really the focus of this talk. And then briefly, we need to have a national strategy to eliminate the virus, and how could we do that? So where did it come from? And when I was preparing for this talk, I had a moment where I asked myself, I've heard nothing about the history of this virus. I don't know how old it is, where did it come from. And so I started delving into the literature. The bottom line, we don't really know. We think it came from sub-Saharan Africa. It probably originated 500 to 2,000 years ago. That's a pretty big range. Not very precise, but that's as close as I could find in any literature. It was originally called non-A, non-B hepatitis, and that's what it was called when I was a student. But also the interesting thing about this disease is it is a disease caused by doctors and healthcare to a large degree. It's spread all over the world because of vaccines and medical treatment, vaccines for yellow fever, measles, anti-schistosomal agents, unsterile needles before people really understood you ought to sterilize the needles before you use them. But so this is largely a degree of modernization and war. So with war became transfusions, massive migration, so people moved around and the virus spread quite a bit in the past 100 years just in the wars. It was first cloned and identified in 1989. For those of you who remember 1989, it wasn't that long ago. Just to remind you, that's when Timothy Dalton was 007 and Licensed to Kill. Dead Poets Society was the big movie. I never saw it, but it was really popular. And most importantly, Bill and Ted's Excellent Adventure came out. So that's my favorite one. So we'll just briefly talk about the hepatitis C virus. It's an enveloped RNA virus. So it's a fragile virus. It cloaks itself in your own cell membranes. That's part of the way it invades your immune system. It wraps itself in your own cell membranes, your own proteins. And it circulates either free, bound to lipoproteins, antibodies. It's just all over the place. And this is a photomicrographs of the actual Hep C virus. I always like to look my enemy in the eye if I'm going to treat them or try to attack it, and that's the hepatitis C virus itself. And this is an awful slide, and I put it up here for really one reason. That's it. That's as complicated as hepatitis C gets right there. It's one strand of RNA, and it'll translate that whole strand into protein. Then how you slice up that protein, you get the different pieces, parts of the hepatitis C. There's only about 10 different proteins that matter. And the really important thing is these 3 non-structural proteins, which are basically involved in viral replication, that are the targets for all of our therapeutics. And I'll point out that there's an NS3, which is a serine protease that cuts up the big protein molecule into the different pieces, parts. There's the NS5A, which is like an RNA binding site, and the NS5B, which is an RNA-dependent RNA polymerase. That's it. Those are the targets we have, period. So every therapeutic you see is going to involve one of those 3 things, with the exception of ribavirin or interferon, which are not as important nowadays as they have been. So the other thing that's interesting about this virus is it mutates like crazy. 1 error every 10,000 to 100,000 nucleotides. So it's making non-viable variants all the time. The half-life is 45 minutes of a virion. Think about that. The virus is only living 45 minutes. You make 10 to the 12th new virions per day in an average person with chronic hepatitis C. So wonder these people are tired. These are cranking out viruses like there's no tomorrow. It's divided into genotypes, and genotypes are only important because it affects response to treatments. There's 6 major genotypes. We're not going to delve too far into those things, but there's lots of subtypes. And basically they determine response to treatment so far, but that's changing. So what happens if you guys all go out and share needles tonight, and one of you has hepatitis C, so you're all going to get infected tonight? Well, about 80% of you will develop chronic hepatitis C, somewhere between 60 and 85%. I think it's closer to 85%. A lot of you will develop an acute hepatitis C illness. You might get jaundice, you become very ill, and then you'll either recover and eliminate the virus and you won't have chronic hepatitis C, or it'll evolve into a chronic hepatitis C situation. But people with chronic hepatitis C, 20 to 30% will develop cirrhosis over 20 to 30 years. So it's easy to remember those numbers. So 1/3 of the people with hepatitis C are going to end up with cirrhosis. And lots of people with cirrhosis are going to die of complications related to that cirrhosis. Hepatitis C is a big risk factor for hepatocellular carcinoma. Cirrhosis is a big risk factor for hepatocellular carcinoma. So that's what's killing a lot of these people who acquire hepatitis C. One of the most impressive things I've seen in the years taking care of people with hepatitis C is they feel terrible. They come to your clinic and you say, how you feel? Oh, I feel awful. I'm tired all the time. I can't concentrate. And for decades we'd say, quit whining. You're okay. Just this virus isn't hurting you, or we're going to treat it with something. You're okay. Quit whining about it. Well, they were actually correct. It terribly reduces your quality of life. Fatigue is a huge problem with hepatitis C, and there's almost a dementia that you get with hepatitis C. Cognitive abilities are clearly affected. So people who have high-level jobs, air traffic control, scientists, people who need very sharp mental skills, that will affect their mental abilities. So when you cure these people with whatever treatment you use, they all will look at you and say, wow, I feel like I'm out of the fog. I haven't felt this way in 20 years. It's rather remarkable, and it's now a documented fact that this really happens. So hepatology lectures get really boring because people start talking about genes and pills and things, and so I like to get real life here. So here's some healthy livers, and you can see the only problem with these livers is they're still not attached to the person. There's one there and one there. It's the bottom side of the liver. You can see they're big and they're generous and they're smooth. Well, if you have cirrhosis, this is what it looks like. This one's actually kind of big for a cirrhotic liver. I'm not sure why this one's so big, but you see it's nodular. It doesn't look right. That's a end-stage liver there. So this is normal liver histology, and you see all these beautiful hepatocytes arranged in nice little cords and the spaces between them, the portal areas, the central veins, all very nice and regular looking. This is a cirrhotic liver. So what's the real difference? Well, the difference are these large bands of type 1 collagen that surround nests of hepatocytes. You're putting these hepatocytes in boxes. Now, if you guys go out and rot half your liver tonight, you'll be really sick for a while. You might end up in the hospital, but ultimately you'll probably recover and your liver will regenerate and you'll get new hepatocytes and your liver volume will increase back close to normal. If you have all these little boxes of fibrous tissue in your liver cells cannot regenerate. So you will not grow new hepatocytes. And I was taught as a medical student, once you have cirrhosis for the rest of your life. You can't regenerate new liver. It's not quite true anymore. We now know people who have early cirrhosis or advanced fibrosis, when they get cured of whatever was causing that damage, we've seen the cirrhosis or the fibrosis reverse. Totally not what I was taught when I was a student, but now it's real. Once you get this advanced cirrhosis like this one, there's no going back short of liver transplant. The other biggie is the hepatocellular carcinoma, and that's a big old one right there. And it's often multifocal because the liver is cirrhotic and lots of areas of the liver are all at risk for developing tumor. So you see lots of little satellite nodules. So if you see a person with hepatitis C, they walk into your clinic, the interesting thing is 11% already have cirrhosis. They don't know it. Their liver is severely damaged, but it's still working, still doing its job. They don't know they have cirrhosis yet. 23% already have advanced fibrosis. They're heading towards cirrhosis. So already you have quite a number of persons with significant damage to their liver. And if you look at who has this hepatitis C, well, it's people in their 40s, 45, 49, this peak right here, kind of the prime of your life. You know, people by now, they're in their job, they're in the career ladder, their days of the risk factors for how they got hepatitis C are long gone, they don't want to think about it, but these are the people who have most of the hepatitis C. So the median age of diagnosis is 47. So one other point about the hepatitis C virus, especially in New Zealand, is the genotypes, because over half of the persons with hepatitis C in New Zealand have type 1, and that's going to be important when we talk about treatment options. So 56% have genotype 1. The second runner-up is going to be genotype 3. There's lots of it in New Zealand. It's very rare in Texas, where I practiced before. We had genotype 1 also as a predominant one. So where is it worldwide? Well, by far and away, China wins. 30 million people with hepatitis C. New Zealand's a paltry 50,000, 54,000. And second is Africa, it's 20 million. In North America, 3 million is higher than that, I believe, and most of those live in South Dallas. So worldwide, it is very common. So 2.35% or 160 million people have hepatitis C. So you think of that disease burden. These people, you know, then you take 30% of those are going to develop cirrhosis and hepatocellular carcinoma. That's a huge morbidity and mortality coming. In New Zealand, we believe it's 1.9%. We're not really sure because it's not a reportable disease here, but we sort of follow Australia and our trends, and that's the best estimate. It was about 54,000 here have hepatitis C. Might be a little higher. The key point is half of them are undiagnosed. You don't know who they are. Hepatitis C antibody positivity in Dunedin. Okay, you think of Dunedin as fairly educated, and we're not all down on the street shooting drugs, but a study here we're going to talk about briefly found up to 4% of random blood samples tested positive for the antibody test for hepatitis C. That's pretty alarming. So this is a study that was done from this institution on the prevalence and knowledge of hepatitis C in middle-aged people in Dunedin, New Zealand. And it's quite an interesting article. Before we get into that, let's give you the same quiz we gave the people for the in the study. So which of the following are risk factors for transmission of the hepatitis C virus in a household? So household contacts. These are the questions I get asked every time I see somebody with hepatitis C. How about preparing food? Is that a risk factor? So if I'm a chef and I'm preparing your food, could I give you hepatitis C? Well, the answer is no. It's not a risk factor. Okay, well, how about if we're sharing the same cups, same forks or knives and stuff like that? Is that a risk factor? No, it's not. How about sharing a toothbrush? I think that's weird, just go on record. I don't know why. I don't share a toothbrush with my wife, but so sharing a toothbrush is a risk factor. You think about brushing your teeth, especially if you get at it and you draw a little blood with the bristles onto your gums, and then somebody else comes behind and uses the same brush, yeah, you can get hepatitis C. How about sharing toilet facilities? This can be a huge public health problem. Maybe we need to have segregated toilets for hepatitis C patients. No, not a risk factor at all. How about sexual contact? Well, that's a tough one. Is it? You know, I get asked that one a lot. Well, I'm going to do the New Zealand thing and say, yeah, nah. It kind of is and kind of isn't. It's not zero, but it's not very high. It's 0.07% transmitted per year among monogamous couples. They did a Japanese study, and they looked at monogamous, presumably monogamous couples, and they had one that had Hep C, one didn't, and it took 10 years before anybody contracted hepatitis C. And then after that, it was really low rate. But the other interesting thing about that study is they had different strains of viruses. So the spouse probably got it from somewhere else. So not much of a contact, not much of a risk. It's not zero though. About breastfeeding. Should these women breastfeed their newborns that maybe didn't get it when they were born? Not a risk factor. So you don't change any of that. So in this study, I didn't, but the questionnaire was sent out on general knowledge and risk factors for viral hepatitis and hepatitis C. And the score was 59% were answered correctly. So it wasn't too great, but yeah, some of those questions are a little tricky, and even in a very educated crowd, I mean, these things are not often common knowledge. Many did not know that the toothbrush risk was there. 93% of the population had no idea that you can have asymptomatic hepatitis C. So they just think if you feel good, you don't have it. 25% had no idea you could be treated for it. And of they analyzed 682 just random blood sitting around in the lab, and 4% had antibodies to hepatitis C. Now, just because you have antibodies to hepatitis C doesn't mean you have it, but it's still probably most of them do. So what are our targets for therapeutics? Well, I told you, there are only 3 things we got. That's it. We can go after the NS3, the serine protease. We can go to the NS5A, which is the RNA binding site, or we can go for the NS5B, which is the RNA-dependent RNA polymerase. The key to understanding all these drugs, there's too many to memorize, and don't bother, but the nice thing is they're all named the same. So if it's an NS3 inhibitor, it's a enzyme Previr, like paritaprevir, prosopravir. If it's an NS5 binder, it's an Asvir, it's like Bidasvir. And if it's an NS5B inhibitor, it's a Buvir. That's it. So any drug they throw at you now for hepatitis C, you can look and go, oh, that's an NS5D inhibitor or protease inhibitor. So what is the history that we've been talking about? It's been around not that long. In 1986, somebody recognized non-A, non-B hepatitis. And it was all this weird, I just remember as a medical student seeing people come into the liver clinic carrying coolers with interferon on ice. And what do they have? Oh, they have non-A, non-B hepatitis. And it was sort of this mysterious thing. But what they found was if you had non-A, non-B hepatitis, you put them on interferon, the LFTs got better. Now they all felt like death warmed over, but their LFTs got better, so the doctors considered that a win, even though it really wasn't. In 1989, we talked about, we cloned it. In 1991, interferon was starting to be used for hepatitis C. In 95, we added ribavirin, and we got a 40% SVR. And SVR is the term that it just equals cure. Sustained virological remission. It's just cure. So people, it's too easy to put words like cure, so we put dumb words like SVR. But 40% on that initial treatment, supposedly we're going to be cured. I've treated lots and lots of people with that regimen. I cured nobody. I made a lot of people feel terrible, and they loved me when they were done because they felt great, relatively, just because they're not on the interferon anymore. And then in 2001, we got pegylated interferon with a 56% SVR rate. And I got a few people cured, but not as many as that would suggest. And then in 2011, everything changed. We got 2 Previrs, so protease inhibitors. And these were awful drugs, but they worked really well. I cured lots of people with that. One of the weird side effects of one of these medicines is it makes you get anal itching. You go, well, that's not that big of a deal. You're going to get cured of hepatitis C. It can destroy your life. So they cause weird rashes, they cause all sorts of strange things, but we cured lots of people. So a lot of doctors just abandoned treating hep C for a long time. I was one of the few that would still do it in Texas, in West Texas. And then in 2013, we started getting the really good stuff. Got next generation. They don't cause anal itching or any of these other weird things. And currently, we're looking at pan-genotypic, once-a-day pills that have a 98% plus cure rate. That's winning the game if you can get it into everybody. So this is just showing you that it's kind of complicated right now. So just genotype 1 without cirrhosis, genotype 1A without cirrhosis, you got this as an option of treating. In New Zealand, we have these 2, ladipizavir, sofosbuvir, which is Harvoni, and then this Bicarapac, and nothing else is available here. But elsewhere, there's lots of other options, but it's still kind of complicated. Well, let's look at cirrhosis with genotype 1A. Well, now you got to change your regimens again, so now it's even more complicated. Well, you say, well, I want easy. So let's just go to UpToDate and get their advice. I just want to know what pill to give this person. There's genotype 1. Oh my gosh, really? I have to sort through that to figure out. So my enthusiasm is dropping pretty rapidly if I'm not a dedicated liver person. So this is the state-of-the-art stuff right now. And again, the names are not important. But if you look at this one called Maverick, it treats all genotypes. Epclusa, all genotypes. And Vilsevi, all genotypes. What we have is Harvoni, which will treat genotypes 1, 4, 5, and 6, Bicarapac, which treats genotype 1. So ultimately, I hope that we're going to have here's your pill, take it once a day for 8 weeks, you'll be cured, adios, and they're cured. But we're not quite there yet. We can treat genotype 1s okay. We really have nothing in New Zealand for genotypes 3, which is nearly half, not quite half, but it's close. So this should be easy from now. I mean, we're kind of done. We've cured hepatitis C, right? We got great drugs. We just have to wait for Pharmac to get on board. Get these drugs here. Here's your pill. You're cured. So when we did get Bicarapac and Harvoni released by Pharmac for GPs to prescribe. And since more than half the genotypes or hep Cs in New Zealand are genotype 1, we should at least get rid of half the Hep C in New Zealand right off the bat. So when we started it, the GPs weren't really buying into this too much. The first year, about 2,000, 2,100 scripts were written by Carapac, and the GPs wrote 423. And in the first quarter of 2018, there's only been 261 scripts by Carapac and only 108 by GPs. And really only 153 by secondary care. So that's pretty pathetic. What's going on? And if you think there's 54,000 people here with hepatitis C, what 50 gastroenterologists we have in this country, we're not going to see all those people. So GPs are going to have to be at the forefront of all this. So why haven't we won the game? That's my question. This frustrated the heck out of me when I was in Texas and we had drugs that were available for anybody to prescribe. They were a little messier, a little more complicated, but nobody would treat it other than me. The family practice, internal medicine docs wouldn't do it. Hepatologists would, some gastroenterologists would, but a lot of people wouldn't. So I got to New Zealand, I thought, oh, it's a national health system. It'll be much better. No, it's still, GPs don't want to write scripts for the stuff. So why are there so few prescribers? That was my question when I was in Texas, and it's still my question here. So I did this study, and this was to identify barriers to treatment for hepatitis C in primary care. So why are these people not treating it? And to answer that question, I asked the GPs. And what I did is I sent out, oh, these are my objectives. I wanted to identify potential barriers, find out, hey, why won't you treat this? What's your reason? I wanted to just look at their attitudes, the current practice. Are they treating and we just don't know it? And look at demographic and regional differences in treatment of Hep C. And then also ask them, hey, what can we do to make you want to prescribe it or be okay with prescribing it? So I sent out a survey. And this is kind of an awful 4-page survey mailed to every GP in New Zealand. And I got that list by internet stalking every GP in New Zealand. I went through the PHOs, got their list of doctors, and looked up their addresses and sent every one of them a survey. And surprisingly, I got 24% back. Which wasn't too bad, I thought. Especially if you look at the length of that survey, a lot of them had lots to say. Unfortunately, I left too much blank spots for them to write, and write they did. Oh my gosh, it was insane. So this is what I found out, that this is an experienced group that responded to the survey, 22 years in practice, so it's a seasoned group. Most of them were in groups of 5. I was surprised. I thought there were lots of solos or groups of 2, but most of them were in groups of 5 or more. Less than 5% are by themselves. And the shocking thing is that 70% said they do not write for Hep C treatment, and nobody in their practice writes for Hep C. They're not interested in managing Hep C. Nobody in their practice, them or anyone else in their practice. 21% said that they are currently prescribing treatment, which was kind of encouraging, but not great. So we said, well, how about if you've been educated? So if whoops, what happened there? Catch up now. Quick review. I don't know how I did that. You only have 2 buttons. I don't know how you mess it up, but I did. Okay. So, careful on this slide. So, this is what we just talked about as far as interest in managing hepatitis C. 70% had no interest in managing hepatitis C. Currently prescribed, 21% said they do. We just talked about those. how many completed medical education activities already? 54%. And how many were offered medical education activities? 65%. So not too bad. Also, we found that history of hepatitis C training was clearly associated with prescribing activities. So if you got trained, you're way more likely to prescribe than if you were not trained in some fashion. And this is by DHB. And you can see that the red bars are kind of the important one. Those are the ones that this is a confidence quota. So on a 0 to 100 scale, 100 being I am the best Hep C treatment person on the planet, to 0 is I know nothing. How confident are you for treating hepatitis C? And in Northland, about 63% confidence quota in treating hepatitis C for people who've been trained, versus you go down here to Whanganui and boy, those people are not too confident, 11% or so. So it's a big variation across the country on how confident you are in treating Hep C. The black bars are the people who have not had hepatitis C at the same DHB, so you can see confidence goes way up when you've had a little training, which is no surprise. Overall confidence was about 38, and we also asked them, if somebody else started it, how confident are you to maintain it? And they felt better about that, 58 number on that confident level. So we said, well, maybe it's by years in practice. Maybe the young guys are way more enthusiastic about it. So the green bars are the people who've been in practice less than 5 years. The black bars are the people who are just about to retire. They've had enough. So if you look at interest, there's no difference there really. Prescribing Hep C, none of these reach statistical significance, but it's the people who are kind of in the middle part of their career that are a little more likely to be offered education, completed medical education on Hep C, but not anything that's significant. So how about if you're in a group by yourself or you're in a big group? And if you're all by yourself, you're a little more interested in things. Again, none of these reach statistical significance at all, but the guys by themselves are a little more likely to prescribe. They're more interested. So what are the reasons? Well, these are the reasons they came up with, and we're not going to talk about them all because there's too many. We'll talk about the important ones. So inadequate reimbursement. Big surprise there. It's always about money. I'm not getting paid for my time. This is complicated. This is hard. I'm busy. I don't have time, for, the amount of reimbursement to, use up my time in this. So that was the biggest one. 44% of the GPs said that's a problem. Close number 2 and 3 is they said, I don't have enough Hep C patients to make it worthwhile. That's a very interesting complaint or barrier. Not enough. Where are all these 54,000 people that are out there? Caseload with other patients. I'm just too busy. 40% said that. I can't get a fiber scan quick enough or easy enough. I don't know how to do it. So getting a fiber scan, which is recommended in our guidelines to get before you treat, a lot of people just said, it's too much. I can't do that. Lack of expertise. They just don't feel like they're up to it. And lots of people consider this a specialist area. So that's also a very important barrier. So let's talk about reimbursement. 44% said that's a problem. So interestingly enough, up in the north, there's 4 DHBs that gave their GPs extra money to treat Hep C. It's somewhere between $100 and $300 per case. So their prescribing rate went up. 31% treated hepatitis C versus 16% elsewhere. So that's pretty good. But those same doctors said, hey, I'm not getting enough money for this. So it's still a problem, even though you're paying them more. But, it's one of those things that you pay me $1 million, I want $2 million. It's just, reimbursement's always a problem. And this is what they would say in those dreaded lines. Money is unfortunately the biggest barrier. It's not viable. Money's good bait. And funding it for a 45-minute consult is a very common statement. So let's talk about their practice and their caseload. So 40% reported that not treating their hepatitis C due to they just don't have enough patients in their practice that have it. So it's not really worth their while. They don't have a hepatitis C heavy practice. So this is, I think, one of the best slides of the whole thing. So we said, how many patients do you have in your practice? Now, nobody really knows. I've never known how many patients are in my practice, but people like to estimate. And so this is on the left here. Is, let's say the GP said, I have between 5,000 and 10,000 patients in my practice. 36% of the GPs said that. Now we said, how many patients of Hep C do you have in your practice? The average was, I got 22, I think, in my practice. And the median was 10. Now if you take the predicted Hep C rate of 1.9% and you put it in those numbers, those people ought to have 95 to 190 patients with Hep C in their practice. You look at the people who said, man, I got the biggest practice on the planet. Not many people said that, but they said, I got 28 people with Hep C. Well, they ought to have more than 380. So they're way not thinking big enough on the number of people in their practice that should have hepatitis C. They're off by factors of 2.3 to 7, which that's a major finding on this study, I think. So in the practice, they say things like, you know, I can't manage this with all the other issues they have. Let me read those. FibroScan availability. This was a really wildly varying complaint. 35% of people said that's one of the problems for them, but it varies wildly from 8 to 67% by DHB. And this is what they told us. Hey, make it easier. We want direct access, which is really interesting that we have direct access pretty much here, but they were still saying they want direct access. They just didn't know it. Training. This is also a big one. Lack of training, adequate training or expertise. 32% of the GPs said, I just don't feel up to it. And their suggestions were just keep educating, increase our opportunities. At present, most of us are very time pressured, doing long days. Practice financial viability is a looming issue. So they're feeling under the gun for trying to keep up with all these mandates. A lot of them believe that this is just a dump from secondary care. We don't want to do this. This should be a gastroenterologist or infectious disease job. That's a big problem. So we said, what do you suggest? Well, interestingly, most of them said, we want more training. Okay. And then they said, we want more money. Fair enough. And we want clear guidelines. But you look at the percentages, it really dropped off. You know, they went from, you know, a third of the suggestions of increased training and reimbursement to, you know, 11%. So their suggestions didn't quite follow their barriers so much. But what we concluded with this study is that the perceived inadequate reimbursement, coupled with them already feeling overburdened, overwhelmed, under the gun, they just don't want to take on new responsibilities. They're already just maxed out. So my conclusion with this is that if you just give them more money, that's not going to fix the problem. It'll help, but by itself, this is not just throw more money at a problem. I do think the healthcare organizations should look at funding based on real world resources and time. And it's going to get easier, so the funding may change as it gets easier. Improving access to hepatitis C education really needs to be a national priority. You know, we only heard back from a quarter of these people, and probably a whole mess of them are just in smaller towns and have absolutely no opportunity to get education. So maybe an online educational activity that's relevant and efficient would be an option. But I think the biggest finding in this was the lack of awareness of the prevalence of hepatitis C is the biggest barrier. These people just aren't looking for it. They're not going to ask all their patients who walk in, well, when you were 20, were you shooting drugs? Well, they don't want to talk about that. The patients don't want to talk about that. So I don't think asking the GPs to find all these people is realistic or going to work. I think you have to have a national health approach. You have to have a public health approach to this type of thing. So I think we need a clear hepatitis C screening strategy and with a public health approach. So that's it.
Thank you. That's a great both update and new information, certainly for me. I'll start with, I'm a paediatrician, so can I just ask you to say a bit more about the breastfeeding risk factor? I mean, when I last looked, this was 7 or 8 years ago, so the information must have changed. There was still a big question mark about, breastfeeding, sore, cracked nipples, blood coming from the mother to the baby.
Yeah.
It happens. So how solid is that bit about breastfeeding not being a risk factor for that baby?
It's solid enough now. Pretty much all the major groups and societies recommend breastfeeding. It's been looked at a number of times. Nobody's ever shown it to be a risk factor by itself. Now, vertical transmission is still a risk factor, but breastfeeding, it's been looked at pretty heavily.
Okay. Yep. Okay, that's good, and it's certainly great from the postnatal point of view, because I don't think they screen mother's blood for Hep C in the antenatal screening.
Right.
Unless I'm wrong. Am I wrong?
No, you're not wrong. It's not part of the New Zealand curriculum. I think one of the problems we've been working extensively in Auckland around this issue as a microbiologist in the community laboratory. I think the main issue is lack of GP understanding of the disease process of Hep C and the epidemiology. And I think you're right that they're not comfortable necessarily asking people about history of IV drug use, and people are not necessarily comfortable about discussing IV drug use. I think also that the prevalence of Hep C in our country is probably pocketed. I suspect that there's higher rates in Dunedin, for example, compared with some other places. Some preliminary data from Auckland and Northland suggested higher rates in Northland, say, compared with Auckland. There's enormous amount of testing going on. So at lab tests last year, we tested 35,000 people for Hep C antibodies. So there is actually enormous amounts of testing going on. It's probably that a lot of the testing has been aimed at the wrong people. It's sort of the worried well, the middle classes who are going and seeing them. We did do an anonymous seroprevalence study some years ago of antenatal samples in Auckland. We tested 1,000 and there were only 3 that were antibody positive. And of those 3, only 1 had a decent antibody positivity level and the other 2 were quite low level and may have in fact been sort of low level false positives, so we do see when testing a low prevalence population. So I don't think that there is a role for widespread screening among antenatal women, pregnant women. I think another thing around screening that's not perhaps well understood, except for me begging on about it incessantly, is that in contrast to some other tests like HIV tests, that hepatitis C antibody test is actually expensive. It's not like expensive like a PCR test, but it's certainly not cheap like an HIV test. And so there is a balance between risks and benefits in terms of the economics of the testing. And I think that's why we've tried to have this targeted testing approach, which I think is valid, but I think it hasn't been managed well in primary care.
Brian?
In terms of the costs, and you mentioned the cost of the test, what's the cost of, I think you said 6 or 8 weeks of treatment or 1 pill? And weighing that up against the long-term costs of chronic cirrhosis, hepatocellular carcinoma that you would be preventing?
It's still a deal to treat and prevent the complications of cirrhosis, the need for liver transplant, and all the medical care of a cirrhotic patient. It's still a good deal. The problem with these medicines, they're horribly expensive. When Harvoni first was released in the United States, and even to this day, it's roughly $1,000 per day or per pill. It's insane. Right. Now, New Zealand gets a cheaper price on things like Vicaripac, and I'm sure they get a cheaper one on Harvoni. I don't know what it is, but I think they're still in the range of $50,000 for a course of treatment.
Right, okay. So somebody needs to do the numbers.
But one good admission for a cirrhotic with a GI hemorrhage and hepatorenal syndrome, you'll blow through that in 2 days.
Absolutely.
I'll just have one further question. You mentioned lethargy as a key symptom. A range of people may want to answer this, but if you present to, the presentation of lethargy is very common. if you're non-jaundiced and you don't have a history of IV drug use, or should you routinely check for, I mean, I would normally check liver functions, but I wouldn't necessarily do the full hepatitis virus screen, should I be?
That's a really good question. And I think ideally, if they're in that age range from 30 to 60, I would. I think a lot of people would argue against that. That's such a non-specific symptom that that's a tough one to say. I think I'd have to probe more for some risk factors, but they just don't want to talk about that. So I think if I was seeing somebody with new onset, just fatigue and achy and sort of that non-specific stuff, that would be part of my work. It's just a Hep C antibody.
Right, so liver functions themselves are not good enough.
Liver function tests are not good enough because lots of Hep C patients will have normal liver function tests quite frequently. It'll spike up and down, and if you don't catch them during the spike, you'll miss it.
And would the labs be happy with us?
Of course. I think probably testing in the community for fatigue is probably one of the most difficult consults that primary care do, and it's one of the things that leads to us getting a lot of tests that we probably look at and think are nonsensical. But I agree with what Dr. Johnson's saying, that patients don't always, it is a symptom of Hep C. I'd like to see an ALT, but you're right, the ALT is not always elevated. So it's better than STI testing in 18-year-old female engineering students, which we're seeing a lot of in Auckland. So I think that's at least better than that.
Thank you. Other questions? Brian again?
Is there any hope of having some sort of risk predictor, an individual risk predictor developed, so that you've got give you more targeted screening and therefore much more benefit?
So there are clearly published guidelines of risk factors out there that if you have any of those, you're supposed to be tested.
Often they don't actually include age, and they do some funny things. That risk prediction stuff is much more complicated than people think.
It is very complicated, and just the risk factors that are listed out there are so broad that it's very hard for somebody to go through all those things.
And the interactions between them.
Yeah, I think and that's really the crux of the problem is how do you find the people who have the risk factors? It's easy to test them, but getting those risk factors out of them is a tough one.
At least a couple of years ago, there was something on, I think, the Hepatitis Foundation website that did have something which I thought was great because it was something people could do in their own home, and you went through and you put in your age and your past activities when you're at university, and then it spat out a risk. And I don't know if it's still there, but it was quite nice because it's something that people could do in the privacy of their own home, and then perhaps say to their GP, I'm worried about Hep C, and then that in of itself is probably enough to go on with testing without a detailed history. So it would be interesting to see if that still is on that website. I'm pretty sure it was a Hep Foundation website.
It'd be nice to have all this integrated. I recently there's a Ministry of Health app around whether you should have your prostate antigen screen. You go through and put in all your preferences, and then it spits out saying, on the whole, this is what you should do. I found it quite helpful. I wanted to see what was behind it, and that's always the issue. You do these things and you say, have they got all the equations right? But they should all be amalgamated somewhere. Other questions? In which case, I will say thank you very much to Steve. It's been a fascinating presentation, and I'm sure we'll have another update in another few years' time to hopefully have a national strategy. Thank you very much.
Thank you.